All right, PK, tell us a little bit about what's going on with your case.
Well, first of all, everybody loves your bow tie here. I mean, I got to tell you, it's a lot of comments from the nurses on St. Patrick's Day and how beautiful you look, and it's amazing. Great, you look great. You really clean up well, man. But,
I don't know if that sounds good.
so listen, before we start, I just want to give a full disclaimer. I mean, just to let you guys know what happened. So we had wonderful sites with obviously Houma, Louisiana, and Dr. Lichtenberg in Arnsberg, Germany. And what happened was, unfortunately, about 8 days ago, there was some issues where Houma couldn't do cases on Saturday, and then Dr. Lichtenberg's cath lab unfortunately had some technical malfunctions. So thanks to Vishal, David, Karthik, and Raman, and our wonderful fellows, we were able to scramble and got 3 cases. I'm not going to say that, well, you guys will judge, but so we got 3 cases to show you. So we're going to start with this first one, and our fellow Michael is going to present it.
Good morning, everyone. So we have a case of CLI. Next slide, please. So we have an 84-year-old gentleman who presented with lifestyle-limiting claudication, progressed to ischemic rest pain, also had a left greater than right, also had a non-healing foot ulcer, so Rutherford grade 3, category 5, and Wi-Fi stage 4. After we did the pictures, we had vein mapping done, and it didn't show any adequate veins for him. You can see his history there, a lot of the typical risk factors: hypertension, hyperlipidemia, has a history of PCI, strong family history, and systolic heart failure, was never a smoker, and you can see his medications there: aspirin, Xarelto 2.5, high-intensity statin, Arni, and Toprol. Next slide, please. So this was some of his non-invasive diagnostics. There wasn't, based on the duplex, there wasn't really any significant disease above the knee, but he has very profound disease below the knee, which we'll show on our angiograms. And you can see his ABI on the right side there. His left was 0.14, his right was 0.2. Next slide, please. That is his foot ulcer.
Why don't we stop there?
Yeah.
So we're going to stop there. We're going to go live to the angiogram because, rather than show it on there, we're going to show you what we did. Vishal, can you
Yes.
describe the angiogram?
So if I can, let's say,
Can you go live on the angiogram, guys?
so this is our picture on the right side, good access right in between the femoral head.
Don't worry about it.
A lot of calcification on the right as expected. And then we go to the iliac. No comments really, it's good, no significant disease. And now this left side as well, like directly on the ultrasound, it's just some mild, moderate disease right there, but the whole crux of the story is for below the knee disease, as you can see. So distal pop, some moderate disease, but then there's a significant, almost like a triple vessel, ATPT, peroneal is significantly diseased right here. And you can see distal reconstitution of the left PT via collaterals coming all the way down. AT is still occluded all the way to the foot. So there are islands, there are occlusions, and there are significant calcifications, which we're going to show you on the dry run. But here we can see the sole artery supplying the entire foot is essentially your PT. There is some shadow of AT that comes back late on, but essentially not as significant at all whatsoever. So the patient's foot is pretty much living on the posterior tibial artery right there. And this is
And you
another
can see
view.
the wound blush here, which is really the heel and the lateral foot along the PT distribution.
And just to give you an idea of a Magda image, this is a dense disease right up there from the posterior tibial, the distal pop into the posterior tibial.
So what we decided to do was we went ahead, we used a gladius wire, Mongo wire to get down to that. But that little curve right there was very difficult to navigate up top. And then we were able to take the Mongo wire and place it at the level. This one or the next one? Sorry.
Next.
Okay, and we're able to place it at the level of the CTO. Then what we did was we walked out our Trailblazer and left our Mongo wire there, and then we decided with the level of calcium. This one,
Yeah.
which is the run? This is the run.
Yeah, this-
Sorry. So with the calcium, wanted to show you the level of calcium. We just wanted you to go ahead and look at the calcium. This is what we're going to go for, obviously today. And then I think we didn't do a dry run.
There was a
Okay,
dry
let me
run.
do a dry run then.
Yeah, there's a dry run before, but sure.
We'll do a dry run here. You could see the dry run at the level of the calcium. So I don't know how it's showing to you guys. So it's heavily calcified CTO. all the way up to our wire, which is at the level of the collateral or what it thinks the proximal PT. So what we decided to do for our plan was to go with the Javelin device because it's the latest and greatest from Shockwave. So we took the Javelin down and would not cross that tight lesion. I don't know if you guys can remember, there was a tight lesion in the distal pop before the TPT or AT. So it's not crossing this, even though I have a pretty good support, a Shahi wire here. See right there? See, I'm not able to cross. So I'm going to go ahead and have David explain the Javelin before we start.
So good morning, everybody. So we have the Javelin device down. So the way that we're going to actually activate this device, we're hooked up to the Shockwave generator. We have the device in place. Now the plan is just to slowly inflate the balloon that's at the tip of the crossing device. We'll initiate the shocks. We'll de-air the system. We'll show all this online, in a detailed fashion. And then hopefully it's going to help facilitate the calcified CTO crossing.
So the idea is to get through this part. I could easily balloon it, but I think I'm going to dissect it. So I think that if I just go ahead and use the Javelin to get through, get to the proximal cap, I may have enough support, and Vishal and I talked about it. Yeah. Now we're also ready for pedal access, ready to go. We have our ultrasound, and we could always cross it from above and below, but I didn't want to mess with the distal runoff because I know he doesn't have a vein for a bypass, which we always got Dr. Rao to get involved in this. But however, because of that, you never know, so we didn't want to mess with that distal target. We'd like to cross from above. So we're going to get started. You guys are looking for any comments before we get started with the Javelin? Everybody agrees with the plan, or?
Yeah, I think it's reasonable. We'll kind of go down the panel, but I think just for everyone here, I think some key features. You already had somebody on the anticoagulation, presumably for their PAD. Lawrence just gave a great talk on the kind of atherothrombotic milieu that we deal with. But I also think it's important for interventional cardiologists for us all to speak the same language. So I think the Wi-Fi classification is very important, when you're looking at patients and you're interacting with your colleagues, so that, that we're all speaking the same language. So how would you guys approach this? You think this is a good Javelin case? We'll just start with Lawrence first.
Yeah, we've used Javelin for something similar to this, and I think it's a good use of the technology. The challenge that will obviously happen is whether or not it crosses easily. If it doesn't cross, then you use it to just get through that first section, and you have to open up another one for the next section. So, but I suspect it'll cross. The issue is it's going to be a two-step. At least in my opinion, it'll be a two-step procedure. It'll be Javelin across, and then you'd have to then expand it a little bit. So you may just pull that, then go in with a balloon, try to get a little bit more, because to me, it's going to be the resistance of pushing and the inertia of that lesion still will capture the Javelin as it goes through. So once you get through it, I think you still have to dilate it a little bit and then go down to the CTO. That would be the only extra step here.
Yeah. What do you think, Marianne?
We have the Javelin in Europe only available since this summer, so we only did 2 or 3 cases, which went well in cases like this. But I agree with Lawrence that it will not be the only tool just to get sufficient lumen to be honest, or sufficient lumen enough. So I agree with Lawrence to go back to some kind of ballooning and then see how it looks like.
Yeah, so Art, you're super skilled. You can just run over to Mount Sinai and get toe access for PK if we need that. But what do you think about the lesion and the approach?
Yeah, we just got Javelin, so I haven't used it yet. My concern is also, okay, use Javelin, and what's the next device you might need, and then you kind of, can't justify the cost. But no, I think it's a good, good use. In terms of planning, I might have done antegrade, just because I'm going tibial, but with a nice reconstituted PT, you always, between ergonomic, comfort, and, access. So I think this is very reasonable. It's got a nice distal access point if you need it.
Yeah, Alfie, what do you think?
Traditionally, prior to this, I would go with the laser. Success on it, not ideal always. Sometimes yes, sometimes no. When I used the Javelin on this topic, so thus far, worked like a charm. And did take it progressively down because there's multiple steps along the way, so not to risk exchanges. And you'll find that little ledges all the way through. It worked well.
Yeah. So Fadi, I think you saw the dry run. You're obviously hugely experienced with ultrasound. Is this, part of the atherothrombotic thing is like, what sort of lesion do you think this is? Do we think it's really like a straight tube of calcium? Do we think it's calcium here and there and then something else in the middle? How would like an extravascular ultrasound help in this case?
I mean, that's a great point. The angiogram, and I think the fellow was commenting on the reconstitution of anterior tibial artery. I would want to see, if not even during the procedure, but from before, what the arterial duplex showed. Are we dealing with end-stage plantar disease here? There's obliteration of the tibial vessels, or there's a hibernating lumen, hypoechogenic space. Fluoroscopy, unfortunately, is not a good tool to kind of distinguish between both. And I'm going to echo what Arthur said about ergonomics. This would have been, it's very skilled operators here with PK, but it would have been a lot easier with integrated access, to be honest with you, just to advance your equipment and your devices. Because you're definitely going to need to work on the plantar loop here, and there has to be pedal loop construction. There's no better than Tatsuya. He's the rendezvous registry, so he's going to tell us about it.
Yeah, would you do anything different, Tatsuya?
Thank you very much. Regarding the crossing or the first target region, I think established bidirectional system, it means distal posterior puncture is, I think, maybe a mandatory because it's very calcified. It's difficult to cross with only antegrade approach. The establishment of the one straight line, where I have to consider the additional below the ankle intervention is necessary or not. But I think this patient plantar artery is well developed and some of the end brush were observed. I think it's sometimes one straight line from the posterior tibial seems to be reasonable as a first step.
Yeah. So PK, we're watching.
I've been listening really well, and I got to tell you, so you saw the javelin cross, the first two lesions, and then over here it seems to be going a little bit off. So Vishal and I decided to go with an Asahi Confianza wire to try to see this. And the reason we did not go, there we go, that's a little better. Yeah. So the reason we did not go into the, what is it called, antegrade was that we felt that, go ahead, turn it on, guys.
Yeah.
Okay. We felt that we could cross this antegrade. And up and over, because we've got the access below. We never put a sheath in below. Okay. We're always able to come from above. And generally speaking, we're very successful at doing this.
Hold on.
So this area is really quite difficult to cross with the javelin. Ready?
No.
Give me 1 second.
Okay.
Let it bleed. One drop, two drops.
Got it. Okay. So right now we're de-airing the system, and that's the problem. And how many pulses do we have with this?
We have 50 left.
Go ahead. Go up. Vishal, how many pulses do we have?
Yeah, another 3 rounds.
So you can see here, this is a very dense, and hopefully I'm gonna have a little bit of forward pressure.
Actually, 4 rounds more.
Hold on.
Letting the javelin work here, but it doesn't seem to want to go.
So for those who haven't used Javelin, for those who used laser before, it was the step-by-step where you could do it without the wire. The Javelin requires, quote-unquote, for the IFUs, that you have the wire across. They kind of wink at you if you want to do it like a laser,
right?
Alone, and it's forward-looking. So it's a 2-atmosphere, right? 2-atmosphere balloon that you can advance, balloon it up, and it's a forward shot of 50 psi. The idea is it follows the lumen as it goes down there. It's better to have the wire down through this honeycomb stuff. But this one's a challenge because of the great unknown, as I always say when we had fellows up in Boston, was it looks 2D like it's going straight, but you never know what it's like internally, right? And you don't know if it's taking lefts or rights. And so sometimes that's where it gets off the beaten trail.
Yeah, so I guess the other question while they're working is, so you've got the below the knee segment, and then you've got below the ankle. Do you have to do it all today, or if you get the BTK segment done, do you just see what happens and live to fight another day on the pedal stuff?
For me, I think that I was going to say, I hate calcaneal ulcers because for the vascular surgeons, correct me if I'm wrong, there's no flap available to a heel. It's such a tightly wound space, and so you really need to do good work here to get the wound salvaged, and then you really need good podiatric care and wound care to offload the heel And if you don't have that, you're going to lose even with a pretty artery. So here, the challenge, in my opinion, I think you need to get not only good antegrade flow, but you want to have the best blush to that heel, which may be those calcaneal vessels. And I think the medial plantar was open, but the lateral wasn't. I would make sure that I get as much as I can out of the foot.
Excuse me, so can I make a comment? PK, I'm Tatya speaking. So I think you are already in the subintimal space. I think it's quite reasonable to do a procedure from the below. So
Yes, that's what we're doing.
Looks like they're preparing already for
Yeah,
pedal
access
access.
from
I can
below.
see that.
Can I get the?
Yeah, we're going to get access from below and come up. So we've got ultrasound. Vishal's going to get access. The Javelin did a good job
the small one.
proximally,
You
but
need the small
distally, because of the severe
Increase
calcium,
the
we
gain.
weren't able to be intraluminal.
Gain.
And David, you can scrub out and help him with the gain?
Yeah.
And we're going to go ahead and show you the ultrasound.
Sometimes the advantage of having pedal access is not even only for crossing the CTO, especially if you're up and over. If you have a floss system from the right groin to the left ankle, at least you have a floss system, so it makes delivery of any equipment that you need. It's not even about even crossing the CTO, it's about even delivering the equipment, especially with the calcium. So, and hopefully that's going to be the case here.
Can I have gain?
So we're just going to go ahead and get access and then go. We need the gain, guys. David, gain.
More.
Is it going up?
Going up slowly.
Is it changing?
Hey, Fadi, would you ever? He has that collateral that's lateral, and it comes in right at the reconstitution.
Depth, please.
To avoid the pedal access, would you ever do
No,
the
no, one back up.
transcollateral primarily as opposed to retrograde pedal,
Take it.
or always retrograde pedal?
You know, in theory, it's very reasonable to do so. But in practicality, what I've found is a lot of these collaterals. You know, we look at a two-dimensional image, but they're in a three-dimensional way. So you don't know if they're deep in the tissue. You don't know if they're superficial. So anecdotally, my experience, it's actually safer to go after the native vessel than to go after these collaterals, because you never know if they're superficial or deep. You might be dealing with compartment or superficial bleeding.
I think that's a great point.
Decrease the depth. It's too much. One last. No, the other way.
I know you guys like ultrasound. I really would just stick this under fluoroscopy, but I think Vishal really wants to do this under ultrasound. You know, it's just getting access is not a big deal. But so the idea is it's a heavily calcified vessel. You see Dr. Kapur is going into the vessel there. Take your time. And
Sorry, my friend.
and then we're going to have to try to wire this from below. So you can see the foot shot here, Fadi. So to me, I think that antegrade flow is enough. I'm not going to touch the arch here. I'm going to just get flow into this vessel, and then I'm going to see how it does, and then I'm going to bring him back because he's a long-standing patient of mine, and then I'm going to evaluate him, you know, with obviously how the wound is progressing, and also more importantly, if I have to get dorsalis pedis access and revascularize the DP, I will. I'm not a big fan of balloon angioplasty, the plantar loop. I know Tetsuya has done incredible work with this, but it's really not for me. You know, I've had some really bad results, so maybe it's me as an operator. But I've decided what I'm really going to go into is just you know, we've done a lot of DVAs and really started doing PDAVs in these end stage. But I don't think this is an end stage foot. I think this is a very salvageable foot.
It's right there.
So.
PK, we can't see the ultrasound. Karthik here. Good morning. PK.
Yeah, the ultrasound.
We can't see the ultrasound very well, so we can't see the vessel.
They can't see the ultrasound, guys.
I think they need to decrease the gain and probably increase the depth.
Yeah.
I don't think this is an end stage plantar disease. I agree with you, PK, because you see clearly that there is a robust flow below the ankle. The medial is open, the lateral is occluded. But we also don't know what's going on with the dorsalis pedis artery, so I agree with you. And this is a very important point, what PK said, because you really don't want to do also, I mean, DVA is such a hot topic right now. You don't want to send these patients to early DVA, because once you commit to that, the patency rates for DVA, even though the limb salvage rates are really good, the patency rates are not the greatest.
Yeah.
So I agree with you. You should exhaust all traditional arterial revascularization modalities before you label somebody as end stage.
I think take a shot just to answer your question. Dr. Garcia mentioned it. It's a conglomeration of things. You do the angio, you see the blush, that's great. If you don't see the blush, the blush for those that believe in like acceleration times, if you have the sono on the table, you see that. You want to grade somehow the improvement. So
Yeah.
The right
In the depth.
visualization of the area helps.
Can you just come out and
An
help?
acceleration time with associated wound healing helps.
No, the other way, please. Give me the other side, right?
Yeah, I mean, I always think that these situations are complex enough to where I don't think it's a mandate that you just do everything all at once, especially if you're not particularly
not the
comfortable.
depth, the other way.
You can improve things greatly just by getting some direct flow, just see what happens. I don't know that you have to do everything today.
The old enemy of good, right?
Yeah, exactly.
Yeah.
Exactly.
That's good.
So Karthik, as we're getting access here, why don't you go ahead and start?
Yeah.
We're having a
Yeah,
Yeah, that's
we'll-
what we're going to do.
Yeah, we'll get going with talks and we'll come back to you. So
Yeah, so Georgie, so to recap, what happened was we ditched the ultrasound. You know, I told you I'm an old school guy. Fadi will be laughing at me because I'm a little older than him, so he'll be like, okay, I'll give the old man a break.
Overnight trailblazer.
So I just went needle access, went right in. Then we switched out for a Gladius Mongo, and then took the Mongo up. And then what we did was we were able to then externalize. How do you play this FluoroSafe?
Yeah, should play.
We came from above with an 018 Trailblazer.
It's playing.
And then we went with the Mongo from below. We straightened out that loop that we were using to get through the calcified lesion.
Still, it is 350.
And,
So we're still
it's going to go a little bit here, so we had to play all this.
fluorescent.
There we go. We had to push the Navicross up.
014 trailblazer.
You got my IVUS ready, guys? And then we went from below with the Mongo and just crossed right in. Boom, no problem. So then we externalized. So we're through and through now.
Guys, I need a
And
trailblazer.
now we're going to go ahead with and use an IVUS. Can I have an IVUS
No,
first?
let's first swap the wire. You have to.
No, it's okay. IVUS first? Okay. So we're going to do a quick IVUS because Tatsuya is there. When Tatsuya is there, we have obviously one of the gurus of IVUS, and I'm sure Eric's in the audience. And
So-
then we're going to try to decide what to do with this.
So just for technical reasons, did you, with pedal access, did you put any form of sheath in, or was it purely wire?
No, it was just wire and a 01.
And a support catheter?
Support catheter, micro catheter. We never put sheets in. I can honestly tell you, I shouldn't say we never. We've probably done it once or twice in my career. Generally speaking, we go antigrade. And here we go. 1 second. Guys, get the Javelin off the table,
Yeah,
please.
let's get the shot.
Get the Javelin off the table for me. I need to see. And let's get the ultrasound machine out of here, please.
Just give it to him.
And so what we're going to do is we're going to go down with the IVUS.
Okay.
Obviously, we're through and through here.
All right, there's.
So the IVUS is lots of pressure here to get the IVUS down.
We'll take the overnight Navicross, the same thing. And I'm going to exchange my wire.
Which IVUS catheter are you using?
We only use Volcano here in the periphery.
One car.
Are you using the short
Unfortunately, it's
tip
not
or,
going.
or tapered?
Don't keep my wire.
I believe it's a tapered.
Yes.
It's not going. So IVUS stops here. So I'm going to run this IVUS for Tatsuya.
Yeah.
So he can at least look at it and give us an idea.
Yeah, bigger
Ready to record, guys?
That's what I entry.
I think you can clearly see the full moon like 360 degree of the calcified axis. I think it's a very, probably here maybe something tomorrow, I'm not sure. But anyway, so you can clearly see the severe calcified full moon calcified plug. Then I use of the shockwave or something, or squatting balloon or serenade, something modification balloon may be reasonable to open up these kinds of the lesions.
So would anybody do any form of atherectomy? Our plan is to go ahead and do exactly what Tatsuya said, is to balloon angioplasty. You can see how tight it is proximally as well. It's to do balloon angioplasty to make a small lumen, and then go ahead and take a shockwave down.
So when you say shockwave, are you saying you're going to take the Javelin back down, or are you talking more like an E8?
No, I'm talking more like an E8 because I think the Javelin is not really going to be effective. We used up all the pulses now. So rather than open another Javelin, which I could, but I think right now if I get a balloon and a lumen, since we're interluminal except that small area, what we're going to do is we're going to go ahead and do a balloon to get a lumen and then try to get everything down. So let's prepare a shockwave, guys.
And
So
PK,
how would you size this?
yeah, PK Lawrence Garcia, regardless if you shock it or if you drill it, what's your ultimate goal? Are you going to just POBA it? I mean, this would be kind of a great discussion on sirolimus-based balloons if we ever get them. But what's the end point here? Is it just going to be a POBA result? Are you going to do a DRS? What's going to be your outcome? That's a victory.
I am 100%. Lawrence, we have really no problem putting in 5 scaffolds. So we will do a scaffold on this one vessel all the way down. I know there's a lot of healthy part to this vessel because we were able to get in intraluminally very nicely. So I think that except that one area of dissection, if I can get adequate expansion, I'll just keep the whole system straight, maybe it'll go. And I'm just going to try to just do a BRS here.
No, I know. Don't worry about it.
So Fadi, what would you agree with
I
scaffold
you
here?
cannot, sorry.
Oh, go ahead.
You cannot see any distal EM size, so you can only see the full moon calcification. If we want to know the more details, I recommended small size 2 millimeter pre-dilatation before the full evaluation of the IBAS or using
Give me a coronary
shockwave or
3.0
something.
balloon,
So
please.
I think the size of the shockwave is completely depending on the distal EM size evaluated by the IBAS. Yes, I completely agree to use something modification balloon or something because due to the make a crack for the calcium, but we cannot know
Get a
the
shockwave ready?
diameter.
3.0.
I recommend to creating a small route to pass the IBAS.
Well, that's exactly what we're doing. There was some confusion. They gave me a Trailblazer rather than a balloon. I want to have the through-and-through wire to give me the support. So rather than lose the through-and-through wire and go with a wire that doesn't give me the support, that's why I pulled out the Trailblazer. So I'm just going to balloon with the 3.0 Tatsuya. I think the distal vessel is quite robust, Fadi. So I'm going to try not to go into that healthy segment and just balloon that area that's occluded, and then go ahead and repeat my IVUS very quickly, and then go ahead and then decide on, after with your guys' guidance, on BRS. So while I'm ballooning, you guys why don't you go to the next lecture, and I'll come right back to you. You can keep me up on the side, and I'll do the IVUS and come right back, George.
Sounds good.
Things are going okay. We got down there to 230, where I told you guys, Fadi, I expressed I didn't want to go into that healthy segment. So I just used a balloon here to create a channel. And then after that, I took what I call the game changer, or shockwave, and we went in and we balloon angioplasty or shockwave the lithotripsy, the segment. We obviously have a lot of shocks left, and since we're fortunate enough to have the 80s. Can you show the angiogram, guys? You're showing the IVUS. Okay, thank you. So we shockwaved this, the whole segment. And then after that, we went ahead and IVUSed. Now show the IVUS, guys.
Keep the IVUS and the angio.
Okay, now
Let's
run
play it from the beginning.
so we have everybody.
Drag it all the way.
Play the IVUS.
IVUS, play. All the way up.
So as you can imagine, it's a Saturday, we're a little, our staff is a little short here.
No, all the way up. Just drag it all the way. Please. Thank you. Now
So
play.
there we go. So this is from the 30 down. It's really a pipe, a lead pipe, as Lawrence was saying.
Mm-hmm. So PK, the beautiful result, and just want to congratulate you on the team. The IVUS really shows why would a shock wave or any modality to disrupt that medial calcium. You can see on the IVUS the negative remodeling and the constraining calcium, especially within the media. You need something to disrupt that. Just simple balloon angioplasty is not going to be helpful. So that's an excellent choice. You're trying to, otherwise we're going to recoil in 10 minutes by the time we end this case. So that was an excellent choice in terms of trying to disrupt that medial calcium. Good, nice work.
So Fadi and panel, I did an angiogram. You can see the angiogram. So this is our angiogram. And IVUS-wise, distal is at 3.0, proximal is like a 3.25. To me, our practice, because I believe in the life BTK data, is to scaffold the whole thing. We have Serenada, we have whatever was needed available, but I really believe that probably with this being the lifeline of the foot, to scaffold it may be the right thing to do.
So, so just to play devil's advocate, Lawrence and I were just talking about this. What about a coronary DES? Just throwing it out there. Would that, I mean,
I'll
there
let
is
the
good
panel
data,
answer
there's good
that.
data, right? So what would be the
Give me the scaffold 3.
differentiator for you between a scaffold and a permanent stent? Because the lesion's heavily calcified.
And I would want to make sure that the balloon is fully expanded there if you're going to put up a bioabsorbable. Because if you put up 3.5
Okay.
in there and the balloon is not fully expandable, then you're in trouble. So that to me that's would be a differentiating factor between like a bioabsorbable versus drug-eluting stent.
So can I just, as we're working here, when we did ballooned body, it was open. We did a non-compliant 3.0 distally, and then the shockwave all the way up with wonderful expansion. So what we're doing is we're doing a scaffold. And so when you open the box, Chris, can you show them the box? There's a check mark, if everybody can see it. Can you focus on Cristobal? So move, with David, your head, please. Thank you, that's great. So you see the check mark, the plus minus, and the X's, I should say. If they, so this is obviously a good scaffold, because if the check is not there, then you know that it's bad and you need to dispose it. Second is, if you can focus on the scaffold here, you can see that it comes with a cover. So you have to pinch and pull the cover off. And then over here, you just load it on, and this is obviously Vishal's eyes are much better than mine. He's going to load it on because we still got the back end of the wire. I should say the front end of the wire here. And then we're going to go ahead and load the scaffold on, and then we're going to go ahead and put it at 30. And we're going to overlap them, and we're going to show you guys what our technique of overlap is.
So, you know, from a life BTK standpoint, it was, for the trial itself, it was upper 2/3 of the tibials, had to be 10 centimeters from basically your ankle joint. So it's a very specific patient population. Heavy calcium was excluded for this, so this is a little off the beaten trail. However, if you look at the first-year manuscript, which is New England Journal, now, 2 years ago, it showed that there was, I think, one patient, Abbott can correct me if I'm wrong, I think there was one patient with 4 scaffolds, but the average lesion length was truncated down fairly significantly. So 2 scaffolds was used, not too infrequently, but it was mostly 1 scaffold for the trial. That's 38 millimeters for the most part, so this will be 2. But it still fits within the IFUs of the device and how the trial was run, apart from the calcium.
So you can see here, there's a great point, Lawrence. What we did here is we took it down to the healthier segment. So I'm going to pull back a little bit here. I don't need to be this far. So I'm going to pull back to 30, like I said, maybe right at the level of the collateral there. And then I'm going to have Vishal go over how he goes up with the scaffold.
Yeah, so it's a slow inflation scaffold. We
Give me
go
another one,
every
Chris.
2 atmospheres, we count for 5 seconds, and then go up 2 more, up to maximum of 9 for 30 seconds. So like you say,
So-
2, then you count till for 5 seconds.
5, 4, 3, 2, 1.
We go up to 4,
Now you get the idea, guys.
and then we keep it at 9 for 30 seconds.
Yeah, the slow release is really important. I think that the data from Varco out of Sydney and then Coombe out of Singapore really showed that this was in the old absorb style, so thicker brick size, as you call it, for the PLLA, was a slow dilatation, which worked well to embed it. There's always post-dilatation that's necessary, IVUS-driven almost always exclusively. And so that's it's a good way to show the process. And I was simply going to say this is the only time you'll see the stent is because of the balloon markers, because there's these 2 little tantalum markers that are like microscopic, and unless you're like at MAG 2, you'll never see them again.
Yeah, and it's remarkably different than the coronary version that we use in absorb. These are actually hard to see even when you IVUS afterwards sometimes, because you just don't have that strut
Give me
thickness.
dry Cindy.
Yeah, precaution.
So now you can see the markers. I'm going to do a dry cine for you.
Yeah.
You see the markers there. So we're going to go with a 3.0 again up top, another 3.0 38, guys.
So precaution.
And if you saw the balloon inflate, oh, hey, Al.
So Prakash, sort of off-label, of course, but we've been doing our own internal just follow-up on these when there's long segments like this. Just out of curiosity, we're putting in regular standard coronary, balloon expandable metallic with these in tandem areas, just so in follow-up we can see what behaves better. Keeping a record of where they are, because on the follow-up, it's hard to see these on sono. It's hard to see them now. It's hard to see the regularity through the calcium as to where they are, but keeping a log of where they are just to see which behaves better.
So that's a great point, Al. So one of the things that we've developed here with Raghu Kaluri is to look at this in almost tangentially through the vein. So Daniela, Kadian, and Raghu are working on something here where we're going to go ahead and do a study where we can actually see these by using the vein to be able to, I guess, illustrate it better and get better clearance or better visualization, excuse me. Did you see my stent? Did it go all the way down?
Not yet. Not yet.
Not yet? I'm sorry, I'm so blind.
Fadi, what do you
Where
think
is it, guys?
about
Tell me above.
3 millimeters for
Tell
the
me above.
tibial here versus,
There it
I guess, would you post it to 325 just to get the little bit bigger, or are you going to stay at 3?
Well, my
IVUS was small.
my personal bias, this is a male, and I looked at the IVUS images. At least proximal to mid, 3.5, 4.0, 3.75 would not be an overestimation for this patient.
Yeah.
Distally, maybe 3.5, but proximally, definitely 3.5 and above.
Agree.
So PK, walk us through the overlap, because this is different with this version than the coronary version. The coronary version, we had to be very, very careful to not have much overlap because of the strut thickness. What's your recommendation here on the amount of overlap?
Well, first we're identifying. See, there's the first strut, and there's the second strut at 25, right?
No. Let's see.
Hold on, let me see.
I think it's lower.
Sorry, guys, it's so
PK.
hard for us to see. There it is. Okay, there we go. We got it. So now you can see it. Sorry, see how difficult it is, guys? So now we want to line up the way Elizabeth showed you yesterday. You see the dot of my balloon is slightly in, and the tantalum markers are lined up perfectly. So we're going to go up here for the second strut. Oh, the second scaffold. Go up. So Vishal is doing the same thing as we're doing this. I'm curious, Tatsuya, about Fadi's comment. When IVUS is telling you it's a 3, do you oversize?
I think at here, 3 is, I think, just size. And then, so as Fadi mentioned, so in more proximal site is a 3.5 seems reasonable, and the post-dilatation with the 4 is sometimes needed to completely embed the scaffold. I think there is compared to the DCB and also metallic stent, so complete achievement complete embed is quite important for the viable scaffold to prevent the scaffold thrombosis in future. Therefore, I recommended to perform post-dilatation with at least 3, especially for the proximal 3.5 should be considered.
Down. Go up again. Yeah, so above this, we're going to go with a 3.75. Okay.
Yeah, so this is interesting. So in this case, you line up the tantalum next to each other. The previous version, you had to have them right next to each other, because if you overlap like that, you had 3 millimeters of it would be.
Wasn't the brick size was it 113 or 130 microns, and then it went down? These are 90, right?
Yeah.
So I think that's a big difference.
Yeah. So PK, we're gonna let Fadi give his talk and come back if that's okay.
Yep. That's perfect. We're just gonna finish up our stenting here, and we'll come back for final pictures.
We're back. Walk us through what happened.
Oh, yep. We're just post-dilating everything now with a 3.540-210. So we're going to go ahead and these scaffolds can be expanded by 0.5. So Vishal will go to 10 atmospheres. Okay, down. So while that balloon comes down, I just want to show you what we did, and we're just going to finish with an IVUS. We went ahead and did a whole bunch of scaffolds to cover the whole thing, as Fadi and everybody and Mary and everybody was saying. And what we did was in the proximal lesion, we did a paclitaxel-coated balloon in the popliteal. We have not taken an angio yet. I just wanted to post-dilate everything and then take a look. So I'm going to go ahead and do an angio and an IVUS. Well, just hold that wire, please, guys. Yeah. And then we're just going to walk this out. Obviously, having the through and through wire gives us a little bit of luxury. Okay, go to low mag here, guys. Okay. I'm going to give a little nitro. We have plenty of pressure here. Okay, flush it forward. Thank you. And in the meantime, while we get the IVUS ready,
Let me just load the cap.
yep, you can load it. Ready? Okay. It's a little quick there, but okay.
That's a good sign.
So very well scaffolded up there. We're just going to look at the proximal. So the area where we DCB looks good, but there's some proximal disease which we'll may or may not take care of. It doesn't look that significant to me. And we're going to show you the foot here before we IVUS. I know we're a little short of time. Let me see.
I think he's just hitting this.
Oh. Can you pull him up a little, guys? Okay, there you go.
Yeah,
That's
good.
perfect. Inject. Oh, looks a little better. You know, I'm not that impressed, but I just think that we might have to go after that anterior tibial artery and maybe go down to the foot if this wound doesn't heal and take care of that little lesion by the ankle. But anyway, for the time's sake, what I'm going to do is I'm going to run the IVUS through.
Just 200.
Mag it up, guys, because you know I can't see.
Yeah, I got. Can you give him a little bit of slack? Yeah, there it is.
Okay, so we're going to start just scaffold. Record, please.
Press record. Yeah, thank you.
So there's the scaffold, very well opposed. A little bit of plaque, but the scaffold is clearly against the vessel. We might have to post-dilate that. You can see the level of calcium, but the scaffold is really nicely opposed against it. Here, we post-dilated with a 4 here, so I'm not going to go any more. This area a little bit more elliptical. Overall, well opposed, again, against plaque, but well opposed. This is the area we DCB'd now. Oh, a little recoil there. And that's it.
Okay, stop recording.
So any thoughts? Are we done? Do we need to do more?
Yeah, any thoughts from the panel?
Yeah, PK, congratulations. I think so. The scaffold is nicely expanded, but I'm a little bit afraid that the distal public P3 segment is in angiography related with radial stenosis observed, and also IVUS findings also showed not so sufficient luminal gain. So I think you should consider the additional angioplasty or something. So
Give me an 018 Trailblazer.
So you mean in this area right here, Tatsuya? I agree. Well, we're going to go ahead and balloon angioplasty this area
Yes.
right here with the DCB. And, this is pre. This is pre. I apologize. We'll take another picture here. Ready, guys? DSA?
Yeah, ready.
Go ahead, load it in the meantime.
Injecting.
Yep, and you can see it's starting to look bad. So would you guys scaffold this with a Zilver or Alluvia?
So I'll hold my opinion. Alfie, what do you think from a surgical standpoint?
I would take probably Alluvia because of the size there. What are you getting up above as a frame of reference?
The SFA, the rest of the SFA is fine, but I'm talking about all the way from, like, say, go live on that.
I'm sorry.
But just proximal top all the way down, I'd probably go ahead and scaffold this.
Yeah, I meant
Right,
diameter. What diameter are you getting in that segment at the top?
About a 5, Al. 5-0.
I would Alluvia it.
Okay.
if
Any other
there-
thoughts?
there's a-
Mayor?
Don't worry.
Sorry, if there's a, we can see the 5 mm, I think a 6 mm self-expandable stent may be acceptable. And so I think the
Yeah.
inflow is quite
That's what we'll do.
important.
Walk it up.
Yeah.
Walk the perimeter
6-0.
out.
Yeah, so we'll just do a 6-0 now. And then I guess we'll be done with that. I don't know if you guys have time to watch. So we're just going to get a 6.0 alluvia. Length is going to be ready to inject.
Yeah, injecting.
So probably 6.0, what, go?
It's like 11, 12, 13, 12.
Yeah, 6 millimeter will be
120?
reasonable.
Yeah, at least 100
6.0, 100 alluvia.
or 120 is fine. 120 is okay.
Yeah, the one other alternative would be a supera in this location, right? Just run it back, it's calcified, it's at the knee.
Walk back then.
But I think that drug-eluting is fine. Alternatively, if you're just dealing with the outflow, this one focal area, I would just do a DCB if you're not going to touch the proximal stuff. That's also possible.
Want to lose it?
Well, we did do a DCB of that distal area that's dissected, Lawrence, but I'm not happy with that result.
Yeah.
Even though we shockwaved it, we did undersize the shockwave because we used the pulses. So I think with that dissection, I think it's like Alfio was saying, I think it's probably better to scaffold this.
Yeah, and I think five is always a weird sort of in between for supera versus something like alluvia, because if you find yourself jamming a supera in there and it massively elongates, then you've lost everything, and so it's probably safer to.
Yeah, for the SUPERB trial, our number one form of restenosis was in the 5s. They were 100%. I mean, not 100%, but they were the biggest restenotic group. So 6 or greater is usually
the other one
the
then.
right answer. I think this is going to be bigger than 6 at some point in its life. I'm not sure that it's going to be just a 5.
Right.
So 100, 120, get both.
Personally, I
So
believe
the card has been put away. So we're waiting to find the card. I apologize, it's a Saturday. So we're just waiting. I'm sorry, Tetsuya, go ahead.
Okay, I think that if you can deploy the 6 millimeter spare here, it's quite its result seems controversial. But if you want to deploy the 6 millimeter spare stent, you require the 7 millimeter pre-dilatation. I think it's quite too big. Right. So I think deployment of the LBR 6 millimeter LBR may be reasonable and more safe.
Yeah. I think the result is quite good. I'm just going to show you the result of the foot. And I don't know, I mean, you guys, obviously the wound is there and is not healing. So the idea would be with the foot looking like this, I think we're going to let the pressure head build and then hopefully follow this wound closely. And then if you can see that the DP comes back quite a bit. So we always can go back and revascularize the dorsalis pedis on another day.
PK, I think putting a scaffold is a reasonable idea. You know, all of this, none of these stents were this, studied within that segment. But just for the sake of discussion, obviously we're looking after wound healing here. We're not looking after patency, because these CLI patients, no matter what you do, they're always going to come back with some sort of restenosis, albeit the same vessel or different area. So. One of the things that I would be concerned about in putting a scaffold, I want to make sure that the vessel fully expands to 6 millimeters. So I'll probably want to pre-dilate and make sure that I'm not having an underexpanded stent in the area there. The other thing is, I'm not so opposed also to what Dr. Garcia was saying, Lawrence. I mean, I think it's reasonable also to not leave a scaffold behind, just
100.
you're looking for wound healing
100.
in this patient, and accepting the fact that this patient is going to come back at some point.
Your 680 balloon first.
Well, the data with Life BTK is, so give me a 680 balloon just to prep the vessel.
Balloon.
So what I'm saying is that I think the data with Life BTK out to 2 years and 3 years now is looking really, really good. I know 2 years been published. They're looking at the 3-year data. So I don't know, Fadi. I think this scaffold works a lot better than we would expect it to. And I'm not so concerned about the scaffolds. I mean, they're deployed quite well. We've got now our 1-year data with the long scaffolds of about averaging 4 scaffolds per vessel. And, our data's been submitted, and so that looks pretty good. I have a good feeling that the scaffolds aren't going to come back, but I don't want it to go down because of the inflow. So we're gonna prep the vessel like you said, and then if we have time, we'll do it online where we will go ahead and deploy the alluvia. I don't know how much time we have. Looks like we have a few minutes. And then we'll rush over to the other room.
Good, go.
Yeah, we're bumping up against the next session. Do you want us to just take a break and then come back to you with the final result?
No, everything is ready. I mean,
Okay.
it's, yeah, you can switch the panel. I'm just going to run over to the other room. The access is there. The pictures are there. We're just going to have to do the wiring. Well, so I just want to show you, so you see Fadi gave us great advice as always. Expand this before we go ahead and put it. So here's our balloon going in. And you can see the balloon is expanding. Come off roadmap here, guys, so they can see it. So you can see the balloon is expanded nicely. Okay.
6, correct?
Up to 11, okay. It's a 6.0. Down? Okay, he's feeling that a little bit.
180?
100, we're going to put a 120 of stent. Okay. Get the stent ready. Hold the wire. Hold the wire. Uh-huh. So the through and through access again is a blessing.
Actually, because I recommended the scaffold, but as Fadi mentioned, this is only a Type C dissection. Finishing with the DCB is also reasonable. As Fadi mentioned, we have to see the wound status, not patency. I think he raises a very good point.
So you can see there's a little bit of recall. I mean, I can code it, drug code it offline, but I really think I should scaffold this. I really do after all this work.
Yeah, I agree.
Oh, you deploy the LBM?
We're doing it right.
That's good.
No, the balloon.
Oh, so sorry.
I don't know. Marianne, what would you do? I'm curious. Would you scaffold this or leave this with a balloon?
I would scaffold it, but with a Supera.
Okay.
Yeah, because PK, we know they recoil now, but they also recoil later, right? So the real question is, what does it look like if you left it,
Little dyno?
you know, within a week or so?
Yeah.
Yeah. I think that's pretty good, huh? Yeah, I think it's pretty good.
This
Want me to go a little bit more? Okay.
Little
Pull the
bit-
wire, please.
A little bit further down.
Further in, PK.
Yeah, we are. We're jimmying it,
Hold on, let me give you a real.
pulling the wire.
Yeah, both sides.
Okay. A little bit more? No, I think that's good, guys, no? Oh, a little bit more, okay.
David, can you?
Let me rail both wires.
And you're going over your 014?
014.
Yeah.
Through and through, we're pulling both wires, still not going.
Yeah, that's, sometimes that's,
A bend is
problem,
a bend
yeah.
is tough. Oof, wow.
Nice.
That's a different way of doing it.
Okay.
yeah, we feel like you're across now. Well,
Little Daiga,
consensus.
I came back again. Just to make it fun, I came back again.
I would just be careful
Yeah.
going
Yeah, like-
over a
that's good.
035 on a 014. The edge can catch your
Yeah.
BPS.
I think that's
And
good.
you won't know it because the BPS.
So far, so good.
Yeah.
Art, yeah, you guys like this spot?
Yeah.
Yeah, I think that probably covers it. Yeah, the other thing you can troubleshoot, I don't know how often you do this, but you
Yeah,
can
that's very good.
always buddy an 018
Nice.
in the system, and then it gets you close to an 035 if you need some extra real estate.
We'll take a your knife, right, we'll do this.
Okay. So, is it all deployed? Show me above. Okay, so yeah, it's all deployed. So I'm just going to balloon this offline, but I'll just take a couple of pictures here. Ready?
Yeah. Knife, right?
Yep.
Sure. Makeup.
6.0 balloon back, guys.
Yeah.
Little 9 pry, flush it through.
Yeah.
Ready?
Ready when you are.
It's already there. Very good. So we're going to balloon this.
Yeah.
And we'll take
Yeah,
a foot
that's
shot.
the rotation.
1 second, we'll take a quick foot shot
Yeah, let's say
here.
a foot shot. With the balloon.
Ready?
Doing now.
That's definitely much better.
Faster and much better.
Yeah, that's great.
So, yep, he feels that one. All right, guys, we're going to sign off here. We'll balloon offline. Thank you so much for all your help and great session. Thank you.
Yeah, great job, PK.